Thank you very much for the invitation, and I got a really great previous speaker who introduced the immunology very well. I'm an immunologist, not a clinician and not a pathologist, so I would like to provide some evidence and also clinical data that the hypothermia is really a good additive to chemotherapy and radiation, improving clinical outcome. These are my disclosures, which have no relevance for the talk and also not my research. The agenda, I would like to show you the recent highlight, the checkpoint inhibition, meaning the harnessing of the immune response to treat the cancer. The cancer immunity cycle is sort of a hypothetical model, how we foresee how the immune system is involved in the control of the tumor and the checkpoint blockade within this cycle. I will show you the success and the shortcomings and the promise which hypothermia might have in that system. Then I will give you some clinical evidence for the effects, immune effects of hypothermia, and also results from preclinical trials. So to start, immunotherapy has been at the center stage of the current treatment of cancer. And I would like to show you that in addition to checkpoint blockade and adoptive T-cell therapy, the hypothermia might be a very good addition to all these treatments, surgery, molecular targeted therapy in improving clinical outcome. Checkpoint inhibition, basically also in melanoma, the trials of ipilimumab, nivolumab, you all know that the promise is that you achieve a long-term remission, which we have not seen before with any other treatment. However, we have a huge patient cohort who is resistant to this very promising therapy. So in this table published in Science, we have high responder tumors, we have those which have an intermediate response rate, where the bladder and the renal cell carcinoma is involved. And those we have tumor entities like pancreatic, prostate, or sarcoma, where we really have a very low response rate. So set together, only a subgroup of patients is responding, and we do not know which patients are responding, which one are not, and our goal is to achieve a higher response rate than we have just received now. Now I would like to show you that there's ample of possibilities to improve response rate based on the cancer immunity cycle, so meaning how an immune response develops and how an immune response is able to control tumor also infection. So first we have to generate T cells, the T cells have to infiltrate, and then the T cells have to recognize and kill the tumor. In the patient situation, we have a failure of elimination of the tumor tissue. There are multiple reasons why these failures occur. We have a bad environment, we have no antigen presentation, no T-cell priming, no trafficking, no infiltration, no recognition. So we have a very complex immune escape, and therefore we have to have a multimodal treatment modalities to combat this immune escape mechanisms. And the immune escape you can see by looking at the tumor tissue, like if you have no T cells, you have a cold tumor, you have an excluded tumor, or you have a hot tumor, and here you have always different escape mechanisms. So we have to also apply different strategies to overcome that. And the checkpoint blockade only works in two positions, the T-cell priming and the elimination. And since I have shown you that we have multiple interruption points, we also need different treatment modalities, like combinations of checkpoint and chemotherapy, vaccination, adoptive T-cell transfer, or anti-angiogenic therapies. And hypothermia is, in my opinion, as an immunologist, a very promising additive to a lot of treatment options. Hypothermia can release antigen, so it can improve antigen presentation by dendritic cells, and I will show you some clinical evidence for that. So an in situ vaccination approach, this will increase T-cell priming, turning cold tumors into hot tumors, and I show you some clinical evidence that this really occurs. It induces chemokines and cytokines, which improve trafficking. It induces stress ligands, which will improve recognition, and it can also help in the elimination by turning down Tregs. I will show you evidence for that, DC activation, or changing the vascular flow. So from that, we can start the cycle and keep the cycle going until tumor is eradicated. Now to the results. I will present you the results from the phase 1 trial that Herr Rachman has already presented. I will show you that there is an immune response involved. So looking at the survival curves of the patients who were randomized to receive neoadjuvant chemotherapy alone or with the addition of hyperthermia, you can see that the survival curves, they separate late. And this is a very good indication that immunotherapy or some immune response was initiated. Then you can see overall that the survival was improved. It was local progression-free survival as well as overall survival. And we, of course, asked the question, why do we have an increase in survival with the addition of hyperthermia to the neoadjuvant chemotherapy? We looked at immune infiltration, and that's published in this paper. We had a biopsy before the induction treatment and before the surgery. And when we looked at the immune infiltrate, we saw a significant change in the number of tumor-infiltrating immune cells. It was in the paired as well as in the non-paired samples. So more T cells were present at the tumor site. And then we looked again a bit deeper, not only the overall immune cells, but we saw that the T regulatory cells, which suppress the immune response by the marker FOXP3, was significantly decreased, so from 33% to 15%, and the PD-L1, the inhibitory, co-inhibitory receptor expressed on tumor cells or tumor-infiltrating lymphocytes, was also decreased. So collectively, one can say the immune cell increased and the inhibitory cells decreased. There was no big change in the CD8 or in the PD-1. And so we have seen that through the addition of hyperthermia or the neoadjuvant chemotherapy per se, there was a turning of the basically cold tumor without infiltrating lymphocytes was turned into an inflamed tumor. And this mattered clinically. Only those tumors post-treatment who had a high TIL infiltration, so more immune cells there, they had a better survival outcome. And this was not seen if one looked at the pre-treatment sample. So there was the importance of the treatment which changed the tumor microenvironment to achieve a better clinical outcome. And the tumor characteristics were the same in both treatment groups. And this was not stratified according to treatment, so even without hyperthermia, if there was a post-treatment high TIL tumor, it had a better survival outcome. However, as we have seen in the large trial, the survival benefit was particularly seen in the group in the arm which had received additional hyperthermia. So we asked the question, why and what does the hyperthermia do to these tumors? And we saw that if we have achieved a post-treatment high CD8 T-cell infiltration, then it was a better benefit, and those only in the additive with hyperthermia. So meaning addition of regional hyperthermia to neoadjuvant chemotherapy in the post-treatment CD8 high tumors achieved a long-term benefit. Conclusion from this clinical trial, neoadjuvant therapy changes the non-inflamed tumor to an inflamed tumor, and the post-treatment infiltrate matters for clinical outcome. And the CD8 high tumors have an additional benefit in the treatment with the hyperthermia. And ongoing trials are trying to evaluate and identify which are the characteristics for the hyperthermia-treated tumors to achieve the better benefit. Second example, regional hyperthermia applied to a young adult with a progressive disease, and we applied regional hyperthermia and low-dose chemotherapy, and after 8 cycles, we had a complete clinical response in this patient. We did peripheral immune cell monitoring and observed that the FOXP3 regular T cells decreased and K cells increased, but a decrease in the naive T cells and an activation of the immune response in the T cell effector cell development. meaning hyperthermia has achieved an adaptive and an innate immune activation with the application of neoadjuvant therapy. From these data, there's the proposal of how hyperthermia might work. We saw innate and adaptive immune activation, and the mechanism behind that possibly is the induction of heat shock proteins. And the heat shock proteins can be membrane expressed or they can be released, and that can lead to NK activation, cross-presentation for T-cell activation, and a better anti-tumor immune response. And this evidence can be supported by preclinical trials and also in vitro analyses. I selected a mouse model from the literature where the HSP70 expression through hyperthermia is clearly demonstrated and a better survival outcome on the mouse. Clearly, hyperthermia induced a CD3 T-cell infiltration, dendritic cell infiltration, better response as seen by interferon gamma, and a reduction in the Tregs as we have seen in the patients. From in vitro, we were able to demonstrate that heat shock protein 70 is able to deliver tumor antigens to dendritic cells for cross-presentation to T cells. We can clearly see here in the confocal microscopy picture that the heat shock proteins are taken up by the dendritic cells. In green, you see the heat shock proteins labeled, and in red, the disease. We can see clearly T-cell activation as measured by the interferon gamma, and that's suppressed by the HLA class 1, indicating that our hypothesis is possibly correct. We could see that the heat shock protein can form peptide complexes with tumor antigens, and these complexes are presented to T cells for a stronger T cell response. As you can see in red here, that the HSP70 peptide complexes have the highest T cell activation. And with that, I come back to the summary. So we can show in vitro and in preclinical models that there is indeed an antigen release and a T cell priming. We have seen that more immune cells are in the hyperthermic tumor, and that possibly leads to better recognition and also to a better elimination. And with that, I thank you for your attention. I'm happy to take any questions, and I thank the supporters of the trial, the SFB and the Deutsche Krebshilfe and the cooperators. Thank you for your attention.